I'm part of the ENT team. So from today, we're going to talk about what kind of patients you guys may expect to see on the floor. Okay. So a lot of my patients, I share a lot of our patients with Dr. Ryder, who you guys met yesterday, also Dr. Kendall. I say like we're two people and or same people in two different bodies. We do kind of the same thing. So I do a lot of cancer reconstruction as well as cancer resection. So I don't know if Dr. Kendall had a chance to come over yet, but that's sort of the things we look at. We work on a lot. So also other patients that we need to work on is facial trauma patients after car accidents, assaults, or gunshot wounds. The typical patient is a PET scan. Here's a brain. Here's the cancer. You can see it's pretty large, sizable tumor there. Here's the cancer coming through the face. And this is sort of what we see after we remove the cancer. You can see the jaw here. This is an X-fix. We use it to secure the bone. Tongue's been removed. Neck, skin's been removed. So no big deal, right? So this is after scapular reconstruction, which is we borrow the bone from the back of the shoulder and you construct. Well, and then this is another patient, similar defect, but we're using a leg bone, in this case fibula. So we'll go over what all these each flaps are so you guys kind of have a general sense of what they are. Other patient with a large sarcoma involving the scalp. Wow. Resection, and then reconstruction. And afterwards.
Wow.
So typical patients, they're elderly, 60 to 80-year-olds. And they typically have stage 4 patients. If you see my patient, Dr. Kendall patient, is going to be usually stage 4. That's why we're involved. Unfortunately, a lot of head and neck cancer patients is a result of long years of smoking and alcohol use. You're going to have a lot of typical issues associated with that. Heart disease, lung problem, diabetes. And if they have cancer inside the mouth, they're also going to have a lot of pain. So as a result, they're not going to want to eat. So they're going to have a lot of malnourished. So poor wound healing is a big concern. A lot of them also had previous radiation history and previous surgery that failed, had a recurrence. So this is sort of like their kind of like an all or nothing kind of surgery. It's like their last chance of survival. So again, with the radiation, there's a concern of poor wound healing. And then as you can see from the picture, these type of wounds are not really something that you could walk around. I guess in Halloween you could, but you're probably not going to live for too long. So these kind of reconstruction has to work. There's no other option. It has to work. Okay. So as you could imagine, there's a significant functional loss, but also cosmetically a huge problem. So a lot of our patients are concerned about social interactions. So some of them, actually a lot of them, obviously they have advanced cancer, they have depression issues, a lot of psychological issues. Okay. And also socioeconomic challenges that you would expect from this population. And anytime there's airway involved, anything inside the mouth, pharynx or larynx, you're going to expect some sort of airway obstruction. So a lot of our patients end up having trachs. So what about trauma patients? So this patient, I'm sure you guys probably know, end of the year, we had a lot of failed suicide attempts, so a lot of gunshot injuries to the face. This patient, you can see is missing essentially the whole mandible. Here he is after the reconstruction. This one is a shotgun injury to the face, brain coming through the face. You can see he had a frontal crani. And here he is after a couple of reconstruction with Dr. Scott Graham. We did this case together. There's a custom implant placed, ALT flap for reconstruction. And eventually going to get a nasal prosthesis. So trauma patients, typically like a car accident, assault, or gunshot injuries. Younger patients, they have generally better wound healing. And as you guys are probably very familiar with it, a lot of times some traumatic brain injury related issues. And airway obstruction is concerned with any intraoral or throat swelling. And CSF leak if there's any skull-based involvement. So what's a flap? So I keep saying this word. So flap is essentially a tissue that we transfer from another part of the body, and then we put it into the head and neck region that we're trying to reconstruct. What's the free flap? So free flap is it's currently the gold standard in reconstruction. It's the same technique used for facial transplant. I don't know if you guys heard about people getting face transplant. Same thing, just that same surgical technique minus the transplant side of things. So we borrow tissue from the patient, disconnect it from the leg or shoulder, where have you, reconnect in the vessel in the head and neck region. So it's very important for that blood flow to continue to flowing until the vessel has grown into the tissue. Commonly we do fibula, scapula, radioform, interlateral thigh flap. So we'll talk about what these are. Now what's the pedicle flap? It's different from the free flap in the sense that the blood supply is left connected. So usually it comes from the chest, like the pectoralis or assistance from the back, and they get rotated into the head and neck region.
Like they fold it up. That's what you
Yeah,
fold it up.
we just swing it around essentially.
That's what Dr.
And it's still stuck on the other
Yeah.
part?
Yeah.
That's what Dr. Ryder was talking about yesterday with the, like, you think there's a hematoma, but it's actually just the muscle turned over.
Exactly.
Wow.
Yeah, good memory. We'll go over that again, okay? So with these free flaps, so this guy's name's Alex Honnold. You guys know, have you heard of this guy before? He's a free, he's a solo free climber. So he's known for the first guy to climb El Capitan, which is like a 3,000 foot granite stone. Basically, he's doing this without rope,
Crazy.
by himself. Okay, it's a crazy guy, and you know, there's a very interesting TED talk on how he achieves that goal. Like he spent like a year climbing up and down, memorized every single move. Okay, so anyway, the point of this is that he can't quit middle of it. He just has to go up and not miss a step. Okay. And that's sort of how I feel about all of our free flaps. So thankfully, you know, obviously with the help of all the nurses, residents, and all the staff involved, we've been able to maintain about 99% success rate, okay, which is pretty good. This is like on par with all the national, you know, centers that do a lot of these. And we probably do about 1 or 2 of these a week on average, sometimes 3 to 4, okay, but 1 or 2 is probably average for us, between myself and Dr. Kendall. Very importantly, every free flap has to work. It's just not an option. You can't walk around like that, right? So, you know, we are super paranoid, and when we do these surgeries, until the day they get discharged, like I don't sleep very well, and that's just the way it is, okay? And you need to come in 2 in the morning. We'll come in and do it, whatever it takes to make sure it works out. And obviously, you know, support from you guys super crucial, and you guys done a great job over the years. I'm not, even if you guys haven't had this talk, you guys done a great job. So what I generally think about is ABC. Okay, I know the algorithm has changed, but I still think ABC. All of our patients, airway obstruction is a big problem, so obviously, you know, just not ideal. So our approach is to trach. Almost all of these patients will end up with a trach, and they stay in there for about 7 to 8 days, and they're sutured in. So there's no trach ties because the vessels are coming around the neck. We don't want to compress this. They're actually sutured in, so nothing circumferential around the neck. So what could go wrong with these flaps? So the main thing is the flap circulation, okay? The flap, once it's hooked up to the head and neck area, these vessels are about 1 millimeter to 3 millimeters, so they're super tiny. So it doesn't take a lot for these to go down, and when they do, it's a disaster. So things that would cause an issue would be wound infections. So you could imagine a very big intraoral defect, you have a small leak. Now the saliva gets into the neck, your carotid is just being soaked in spit, which is not good. Okay. And also, it kills a flap. So it doesn't take a lot for these flap vessels to go down. So again, this flap failure is bad. So our approach for this is we keep them on IV antibiotics for about 7 to 8 days. Obviously, a lot of this applies in the ICU side of things, but you know, you may see them afterwards. So IV antibiotics, very important. We monitor the drains for any saliva leaking for the first 7 days. If we see anything that looks like spit, we may send it for amylase to see if there's any sign of spit in there. And if there is, we'll usually bring it down to the OR and wash it out and reclose it area because we don't want the spit keeps coming down into the wound. I tell my residents to change the gloves frequently. Unfortunately, we have some E. coli infection in the head and neck area. Could be because the patient is dirty, but it could be also from contamination, is my guess. So whenever you're working with the drains, change your gloves, applying ointment on the incision, change your gloves. We put these people on very high protein, a high calorie diet, almost similar to like burn patients. I mean, you could imagine like head and neck issue and like we're harvesting a huge leg flap. So it's just a lot for the body to go through, okay? So we really crank up on the 2 feeds. And also we focus a lot on thyroid hormone, make sure that thyroid hormone stays normal. Now the other important thing is we want to make sure the patient does not have nausea that would lead to vomiting, because obviously if you vomit, just not good. Gastric content in the neck's not a good thing. The other important thing to remember is I'm not sure if you covered this, but again, the compression around the neck could be a big problem, or the chest if it's like a latissimus flap, which we'll go over in a bit. But also the important thing is to avoid hypotension, okay? These vessels are super small, 1 millimeter, 3 millimeter. If the blood pressure is low, just not enough blood flowing, it's gonna clot. So we wanna, I'd rather have them be hypertensive than hypotensive. And what we do to ensure that is we do constant monitoring of the blood flow. So here's an example of what that looks like. Here, this is an anterior lateral thigh flap. Patient had a big ear cancer with temporal bone resection. Here's a vessel, and this is magnified. Okay, this is probably like a 2 millimeter vessel we're looking at. So this is an artery Doppler, and this is a little plastic that we use to hook up the veins. So there's also Doppler for 2 separate veins. Okay. So I'm hoping this works here. So this is what the arteries would sound like a heartbeat. Right? Now the veins are a little bit more random sounding. So you can see when I push on it, did you hear the whooshing sound? This directly transduces, so that's what we call transduction. So what's happening is, artery just sounds like a heartbeat. And the vein, when you press on it, the blood will flow back into the jugular vein, and then it flows back in. So it creates that whooshing sound as the blood moves, and it tells me the vessel's open. Okay? So these are the things that we check for. So I'll just do it one more time just for you guys to be familiar. So the artery comes in with the gray box, and then when you check artery and vein, you want to turn off one versus the other, otherwise it'll interfere with each other. So anyway, so this is vein. So this is sort of the late sign of typically majority of the flap failure will result from the vein compromise. And this is what it will look like. It's like purplish skin. When you prick it, it's like dark blood or like motor oil, like really black looking blood. This is too late. So this means the flap's already pretty much fried. So we'll still take these down to see if we can salvage it. But if the skin's already changed, it means the whole artery, capillary, and the veins clotted off. So we have to throw it out, which is not good. Okay. So the Doppler is crucial for early detection. So a lot of times we really rely on the Dopplers, and this is sort of what helped us maintain that high success rate. The first 7 days is super crucial. Now, what do you do if these don't work? Again, when they come on this floor, it's probably outside the 7-day window. It's not as crucial. But still, you may still see that, maybe at the ICU side of things. So if it doesn't work, first check the power. So these been abused and used a lot, so they sometimes don't work. So make sure the power is plugged in. They all have a little AA battery that's acts as a backup for the power. So just check, if those are working, if they're hooked up. They should light up, okay? So this is the power button for the black, and this is the power for the gray one. And also the connections are hooked up, meaning this connection should connect it to the Doppler that goes to the patient. So make sure those are hooked up properly. Is the channel, so these we usually monitor 2 vessels, so there's channel A and B, so make sure they're on the right side. Now what if it still doesn't work when you check those? You want to step page ENT resident. Doesn't matter if 1 in the morning, 5 in the morning, call the radiant resident, call the senior resident, nobody calls back, call me, call my cell phone, just hammer page me. Because we have about 5 hours to save this flap. So the minute it goes down, now there's no blood flow, it's just slowly dying. Okay, sort of like equivalent to losing a leg. Okay, it's a pretty big emergency for us, for all of us, obviously. So the first thing the resident will do when they come is to try a different box, because obviously these boxes use a lot, so they sometimes fail. So if you could ask, or if you could find an extra one to try it out, that would speed up the process. The next is they'll poke the flap to see if it bleeds. Okay, because sometimes the Doppler just comes loose. Again, when they are on this floor, probably not a big problem at this point. Usually 8 days out, it's not a problem, but we'll prick it to see if it bleeds. If it doesn't bleed, that means the artery's down or the veins down. If you prick and it's like dark blood coming out, it means the veins clotted. So it's like basically dying. So again, this is an emergent situation for us. And we generally order 10,000 milliliters of heparin on the way down to the ER. So the reason for that is if it's already clotting, it's going to progress. So we want to prevent the progression. Okay. So commonly used pedicle flap. So we'll start out with the pec flap. Okay. The pectoralis flap, he's a guy with an open condyle defect. You can see he has a mandible remaining, so it's like this joint is gone. This is temporal bone here, the skull base exposed. He's alloy to kind of recreate the bone here. And the skin's gone. So we're going to put this kind of a fancy condyle joint. Here we go. So secured it to the bone, to the skull base there. Obviously, patient has a big skin defect. Can't walk around like that. So here we borrow pectoralis muscle and skin. So we kind of harvest this tissue here and then rotate it into the head and neck area. This is what it looked like. So from here to there. Okay. And we tunnel this under the skin. You can see there's a little bit of bulge right there. That's the muscle. Okay. So what do you look for? So first, check for skin flap color. This should kind of match the patient's chest skin. Okay, if they're African American, it'd be kind of darker pigmented. Whatever the skin, wherever it came from, it should be what the color is. We want to avoid compression here because this is the muscle bulk and blood vessel coming up that way, and it starts out right here. Okay. So this next swelling is not a hematoma, just your muscle, like you. And if you see a resident trying to poke it with a needle, tell them it's probably a muscle. Okay. Hopefully they won't do that. This should go better. The other thing is we don't like getting PICC line on this side. So this vessel, this pec flap comes from the subclavian system. So if the PICC line goes in and clot, the whole arm's going to clot off and the pec flap. So that's not what we want. So PICC line goes to the other side.
Should we do blood pressures on the other side of the front too?
Probably better, yeah. It's not dangerous, but the PICC line, you can get. I'm sure you guys seen those clot off, like the whole arm. So that's really a big deal. But blood pressure should be okay. Sorry, my PowerPoint is going crazy today. Now check for any chest hematomas. Look for any swelling, any significant bleeding out of the JP drains. I forgot to mention here. Activity-wise, they can use their arm. There's no restrictions. Just going to be more pain tolerant. Latissimus flap. There's that girl that we saw earlier, big sarcoma.
Wow, that's terrible.
Yeah. So this is after the resection. We burr the bone down. So we borrow tissue from the back, and we string it all the way up to the head. That's what we did.
Crazy.
Okay.
How did that sarcoma get so big?
Just
Quickly?
ignored it.
Ignored it.
Yeah.
Oh, not just, okay.
Patient came in for diarrhea, so that's clearly not why she came into the hospital.
Oh my gosh, diarrhea.
So,
That's diarrhea, that's bothering me, but not.
What's that on your face?
Yeah.
But,
Poor thing.
oh my.
so the important thing about this flap, again, check the skin flap, but this flap is coming from here, so we cannot have anything compressing this whole pathway coming up, okay? And unfortunately, the patient, they are doing chest PT vest on, instead of like the bed vibrating, they put this vest on them. That's not good for the flap. So that resulted in some of the distal end of the flap to die off. So that could have been preventable. So I didn't even know that we had that until that happened to us. So no chest PT on latissimus flap patients. Now, I also asked them to slightly abduct the arm like this because the vessel's like right here. Usually put like a couple pillows here, just for their comfort essentially. Okay. In terms of same thing, they'll pick one on the same side. And activity-wise, really no weight restriction. I just asked that they don't compress the axilla. They're welcome to work with the PT. We generally expect them to have full range of motion again, like people play golf, they go hunting again, but it takes time. A lot of it just from the pain from us cutting the bone or muscle in that location. And check for back hematomas. So free flaps. So again, free flap, disconnect, and then connect to the neck. So not like these chest ones we talked about. Starting with the scapular flap, you can see a big cancer starting right here. You can see it as sort of, this bone is completely different from the other side here. Can you guys see the difference there?
That's all eaten
It's
up.